Welcome back, students, to another explainer for Decode Healthcare with Harshal. We are officially on Part 58. Now, in our last session, Part 57, we broke down the post-acute care transfer policy and how those tricky discharge status codes directly impact a hospital's bottom line. But today we're looking at something even more fundamental to the entire revenue cycle. Look, did you know that a single missed word in a patient's medical chart can literally cost a hospital thousands of dollars? Seriously, it's true, and we're going to see exactly how that happens today. Before we jump in, if you're enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal.
Here's our agenda for today's masterclass. We'll be hitting the core payment formula, understanding relative weights, the power of CCs and MCCs, and finally, the real-world revenue impact.
All right, let's dive right into Section 1, the core payment formula and IPPS architecture. Okay, so the entire IPPS revenue cycle basically hinges on this one crucial formula. Hospital payment equals the base rate multiplied by the DRG relative weight. You see, under this system, Medicare does not pay based on individual services or line items. A hospital doesn't get paid per aspirin or per bandage or per hour of nursing care. Instead, the payment is fixed before the patient even walks out the door. Now, behind the scenes, that base payment is actually calculated by taking a labor portion, multiplying it by a geographic wage index, and then adding a non-labor portion, before finally multiplying the whole shebang by our DRG weight. Let's break down that base rate. Think of it as your starting line. This is a standardized dollar amount defined annually by CMS, but, and this is a big but, it is heavily adjusted for every single facility. CMS applies that geographic wage index I just mentioned to account for local labor market variations, because, paying a nurse in Manhattan costs more than in rural Ohio. Then, teaching facilities get indirect medical education and direct graduate medical education adjustments, while safety net hospitals treating low-income populations get disproportionate share hospital funding. On top of all that, this base rate can be penalized or rewarded based on quality metrics through value-based purchasing and the hospital readmissions reduction program. So, all these factors combine to create a totally unique starting point for every single facility's Medicare payments. Now for the second half of our formula. The relative weights, or RW. This is essentially a number reflecting the average resource intensity needed for a typical case in a specific DRG. The baseline is exactly 1.0, which represents the overall dead average hospital case. So if a DRG has a relative weight of 1.3, it means that specific condition requires roughly 30% more resources than the average patient. It's pretty straightforward. A higher relative weight means a hospital spent more resources. We're talking more nursing time, more complex labs, heavier medications, all to treat a more complex patient.
Moving right along to Section 2, understanding relative weights and exactly where they come from.
The system classifying these patients has evolved dramatically since it was first dreamed up at Yale University back in the 1980s. Today, CMS uses what we call the MS-DRG, or Medicare Severity DRG. This modern grouper software is essentially a massive, highly complex logic engine. It takes all the clinical data, specifically the ICD-10-CM diagnosis codes and the ICD-10 PCS procedure codes, and crunches them to determine the severity of the patient's illness. This is what directly links the clinical complexity on the chart to that relative weight we just talked about. And the grouper software doesn't just guess, right? It follows precise, hard-coded logic steps. Step 1 is identifying the principal diagnosis, or PDX. This is the main condition established after study to be chiefly responsible for the admission, and it's what determines your base DRG family. Step 2, it checks the secondary diagnoses for any complications. Step 3 looks for major procedures. And finally, Step 4 adjusts for demographics, things like age, sex, and even discharge disposition. Basically, every single clinical input alters that final calculation. Now, the very first major fork in the road for the MS-DRG architecture is the medical versus surgical split. Within the 25 major diagnostic categories, which, by the way, are based on organ systems like the circulatory or respiratory systems, cases are partitioned into two completely distinct groups. If a procedure is present that meets the CMS definition of a major operating room procedure, the case is assigned to a surgical DRG. If not, it goes to a medical DRG. And as you might expect, surgical DRGs generally have much higher relative weights. Why? Because the resource consumption of an operating room, the anesthesia, the surgical recovery, it's vastly higher than standard medical management. All right, Section 3, the power of CCs and MCCs, which act as our payment multipliers.
So once the base DRG is established, the grouper uses the famous MS-DRG triplet structure to assign a severity tier. If a patient has a secondary diagnosis flagged as an MCC, that's a major complication or comorbidity, boom, they get bumped to the highest payment tier. If they have a standard CC, it lands in the middle tier. And if there are no secondary diagnoses flagged as a CC or MCC at all, the case falls right to the lowest payment tier. But here is the kicker. These secondary conditions must be clearly documented, and in most cases, they must be present on admission or POA to actually count toward the DRG weight. This ensures hospitals aren't financially rewarded for hospital-acquired infections.
To put this into perspective, consider a basic DRG. Let's say a patient is admitted for simple pneumonia with absolutely no other documented issues. That requires a baseline level of resources. Now, compare that to a patient admitted with sepsis, which is complicated by acute renal failure. That's a textbook MCC. The resource used for the second patient is just astronomical in comparison. We're talking ICU monitoring, specialized medications, maybe even dialysis. The MS-DRG system is designed to compensate the hospital for that higher severity, but, and this is absolutely crucial, only if the documentation explicitly captures those MCCs.
Which brings us to Section 4, the real-world revenue impact. Let's talk dollars and cents.
Here is a conceptual scenario straight out of our training materials. Two identical patients come in with pneumonia and both have underlying COPD. In the first case, the physician notes shortness of breath, but fails to explicitly document the COPD exacerbation in the discharge summary. Because of that, the coder must assign DRG 195, simple pneumonia without CC, yielding roughly $6,200. In the second case, the physician clearly links the pneumonia and the COPD. The coder can then assign DRG 193, simple pneumonia with CC, and the payment jumps to $8,500. Think about that. That is a devastating $2,300 loss in revenue from a single missed secondary diagnosis. This right here is why we have the ultimate mantra for CDI and RCM professionals. Clinical accuracy leads to coding accuracy, which ensures financial accuracy. If a condition isn't documented clearly, specifically, and unambiguously by the physician, the medical coder legally cannot assign the higher-weighted code. Look, it doesn't matter how sick the patient actually was in the bed. All that matters to the groupers is what is captured in the ink of the medical record.
Let's wrap things up with Section 5, summary and a quick teaser of what's next.
Here are your major takeaways for today. IPPS reimbursement is driven by the base rate multiplied by the DRG relative weight. The MS-DRG system carefully splits cases into medical versus surgical partitions. Comorbidities and major comorbidities act as those all-important payment multipliers. And of course, accurate documentation is your ultimate shield against massive revenue loss. Now, one last thing I want to mention. What happens with catastrophic, ultra-resource-intensive cases where costs just blow way past these standard formulas? Well, CMS provides what are called cost outlier payments as a financial safety net. To calculate this, they use a cost-to-charge ratio to convert the hospital's billed charges into estimated costs. If those costs exceed the standard DRG base payment plus a specific fixed loss threshold, CMS steps in and pays a marginal cost factor of 80% on that excess amount. It's a vital protection for hospitals taking on the most extreme cases.
Coming up next in Part 59, we are going to tackle the absolute enemy of the relative weight, unspecified codes. We'll dive deep into clinical documentation integrity interventions and effective physician query strategies so you can legally and ethically clarify the medical record. As always, if you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. I'm going to leave you with this final, provocative thought to take back to your teams today. Will your hospital's clinical documentation leave thousands of dollars on the table today, or will it perfectly capture the true clinical picture? Keep pushing for accuracy, keep learning, and I will see you all in Part 59.